The information provided on Dr. Tom Roselle Live by Dr. Tom Roselle, D.C., interview guests, show co-hosts, or substitute hosts is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. It is for general information purposes only. Information from this broadcast should not replace the appropriate consultation and examination process by a licensed physician. Always consult your own physician prior to changing any current medical directive or prescription.
Hey everybody, Dr. Tom here. Welcome to another episode of Ageless Health, our live stream. And we want to begin to give you more and more information so you can be proactive. Remember, your health is in your hands. It's a do-it-yourself program, if you will. We're going to continue a conversation on headaches, but we're going to talk about structural components and what happens with that. It's really important that you understand that headaches often will continue to persist if the underlying why is not identified. Unfortunately, so many of us are put on all kinds of medications or take a couple of aspirin, call me in the morning type of attitude. We want to make sure that you understand that that doesn't fix anything. We want you to understand that there's a way of making that happen. The Roselle Center in Fairfax this coming Wednesday evening will have a program on this specific subject. And remember that we have limited seating. We'd love to have you there. Join us. All you have to do is go online at drtomroselle.com. You can register there. Or simply, if you'd like to do it the old-fashioned way and pick up the phone, call 703-698-7117. Today's program, I have a very special guest, somebody who has been with me as a senior in my practice for many, many years. And when I say brilliance, that's understating this man's expertise and what he has in between those 2 ears and that gray matter that, that we all perform. Well, his is at a higher performance level than most people. But more importantly, what he brings to the table is experience over decades of healthcare, and he understands this mechanism. Today, we're going to focus on the structural components of headaches and what that really means. And this Wednesday evening, we'll talk about migraines and the multiple kinds of migraines and how to correct those things, and so you don't have to suffer with them ongoing. Having said that, Dr. Scott Lamp, welcome to the program, my friend.
Yeah, thanks, Tom. Good to be here.
It's important, in our world of chiropractic, applied kinesiology, natural health care, integrative care, if you will. We look at the body from a multidimensional platform, a structural, chemical, emotional paradigm, if you will. So what's really important is the understanding of why something comes about. Headaches and low back pain are the number 1 and 2 things that drive most people into doctors' offices and literally spend millions and millions of dollars, either direct cost to them because they're not working, they can't retrieve it, or their employers are suffering because of lack of production. So in the world that we're in today, with inflation rates going through the ceiling and everybody's struggling to try to figure out how they're going to meet ends, if we could solve this one problem and get people to be able to function and work and contribute, and God knows if you got a headache, you can't think straight. Scott, let's get into the basics of structural headaches. What are the triggers? What are the causes? Let's stick at this point from the neck up, if you will, and let people understand why headaches come about. In your experience over the years, what would you finger point as being some of the most common patterns that are a result of headaches?
Well, some of the most common patterns we're talking about, I think the number 1 type of headache you usually have is tension headache. So there's a lot of different things that come into play there. Okay, you got the emotional part too, that stress does certain things. And when we stress, sometimes people feel it in their jaw, they feel it in their neck area, and it pulls on different muscle groups that are around that. Now, when we have these things, we have to figure out where's the nerve being reactive, where's the place that could possibly happen. Either we're talking about a nerve, we're going to talk about either compression or a vascular change of some sort, inflammation, some pressure being put on that. And when we pull the pressure or put our heads in different positions, we're not, so to speak, in neutral position. We're dropping our head down. We're looking at cell phones. One of the interesting thing about the weight of, and you know how much I've worked with ergonomics, Tom, is that if I had my head neutral, I had my head up straight and forward, it might be 14 pounds, in your case, about 16 pounds for your head. But that's a compliment, Tom.
Very nice guy.
But if I drop my head down and I go down and look fully flex my head forward, that is now 60 pounds of pressure on your head. And one of the things that happens is now you got muscles on one side tight, one muscles on the other side are too loose. There's a constriction of blood flow. And when we have these constrictions, we could build up pressures. We might pull and stretch a nerve. And that's when we start creating some of these pain patterns. And a lot of these pain patterns you'll see, especially on tension headaches, are going to be on the back of the head, maybe the top of the head. You'll have things around the ear, kind of like almost like, I think of like a coat hanger goes around here. Usually comes from the trap area from that being squeezed. And we can either have stress from that or positional change. And there's a lot of positional changes with all the new things that we're doing, especially things like you've heard, and you said the term before, is tech neck, when you bring your head down and you lock it in this position. I think the other thing is we do a lot of things called cranial nerves. And cranial nerves are areas, it's kind of like the midbrain. It runs in the front part of the throat area, up towards the back part of the thyroid area. And this is where the cranial nerves actually come from the brain, goes through the bones, and then go into a particular area. For example, the optic nerve comes up through the eyes, but has to go through the cranium to get there. Well, these bones shift and move. And if I'm in awkward positions or torque positions or things like that, then I can actually create and bring these things up. What we found, and I think it was interesting when we had this, we had a class at the seminar that Tom and I were at, or Tom was actually hosting and doing. And what the realization is when even the doctors, when they try to do a check on somebody, especially cranial nerve checks, do you check them in the neutral position, or you put them in a change position, or ear to the side, head back, rotation? Because these small nerves can be stretched and pulled and torqued inside all these 22 flexible bones we have in our skull and create a problem. And we can miss some of these things where we're looking at, hey, the cranial nerve tests are fine, but if he drops his chin and all of a sudden he has problems moving his tongue.
Scott, real question. You talked about the optic nerves going to the eye.
Yeah.
Now, that's a functional nerve.
Right.
But sometimes people get headaches, feels like there's a knife in their eye and going straight through.
Yeah.
Is that what you're also alluding to? Does it have a sensory portion, or is it the motor portion causing the eye muscles not to work the way they're supposed to, and that causing the pressure? Which one is more common, or is it both?
I think it's a combination of both. You're going to have those, and not just there. I mean, we talk about also the trigeminal nerve that comes around across the facial aspect, and that actually has both motor and sensory components. So if you're irritating a nerve to be a sensory motor, the sensory one, obviously you're going to have a sensory reaction. Motor could also create a sensory type problem just because of its muscles too tight, and it changes the volume flow and going through that area or stretching it can create a problem. So it's probably both.
Let's talk about cranial mechanism itself, and then I want to get into how we identify some of these things. In our world, we talk about misalignments in the spinal segments, the pinch nerves, if you will. But basically, it's a off-centering, abnormal juxtaposition of the spine that causes either a stretch or a compression reaction on the nerves that come out of it, and that obviously causes pain. But you have 22 bones that make up your noggin, your skull, right, and they move like little sawteeth interdigitations as you breathe in, as you breathe out. Mechanisms to pump spinal fluid. So how often do we see normal, and I'm using the word normal, headaches because it's not supposed to be there, but there's too many people that have headaches ongoing. It's not normal. You shouldn't live with it. It's not something that you should deal with. How often is that cranial aberration, that mechanism, not working properly that lends to that distortion called a headache?
It's an interesting question because the thing is, it depends on the habits of the person, what you're looking at. A lot of different things can play parts with it. We all know that cell phones are one. We just kind of alluded that before. If you chew gum, one of the things you chew on one side, the left side of the jaw. How many of us has had dental work done that's actually been overly done? So you have those kind of things. postural habits when you're sitting at work and your head's dropping forward, or you're just leaning back, or who's a kid's going out there playing sports and getting something off their head, for example, in soccer, the injuries that we have. There's a lot of things that come into play in this. Even going back to the fact of, okay, what's happened to remodeling of the skull when somebody's born. I mean, you got a vaginal delivery, you got forceps, you got vacuum distraction, the pulling of the doctors on the head aspects, and some of those you have these kind of like cone-shaped heads. Did that go back correctly the way it's supposed to, or the body just says, okay, this is the best way we do it, and so it's going to sit there, and you're going to have deficits that are going to be associated with that type of stuff.
So what you're saying is this could be a lifetime problem when it starts that early, and if it's not identified and corrected, it builds up over a period of time.
Yeah, death, taxes, gravity. It's on us all the time.
Got it. One of the things I tell patients is don't hold your breath when you sneeze or you cough. And that can cause compression, irritation, compression on the membranes of the brain and the soft tissue, but also irritation, separation, and jamming of the plates that we talked about that make up the skull. So now that whole rhythm is off, and chewing gum, as you talked about, an unbelievable triggering mechanism. But you mentioned dentistry. When you go to the dentist, more often than not, there's guys that really know what they're doing, but they will measure the temporomandibular position, if you will, by putting a carbon paper in their teeth. And they'll say, tap, 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 grind, grind, grind. And that's how they correct the position. But unfortunately, what takes place is that the patient's about a 40-degree angle, 45-degree angle going backwards, sometimes a little bit more than that. And when that happens, the jaw drops backwards. Right. And so subsequently, they're matching the teeth, but they're not matching the temporomandibular joint or the pump handle that makes up the head. Yeah. And so subsequently, you're not moving the mechanism, or it's locked in an aberrant position. And now we see all of these things called pain.
Yeah, improper dentures. I mean, when they put the dentures in, like, how often do you go to sleep and now you take your dentures out? It's like, well, why are you putting them in a position or setting them up in a position that you're not going to necessarily be in using them? Doesn't make sense.
Yeah, it doesn't. Scott, there's a whole world out there right now using Botox. Right. And, they're injecting, the skull, they're injecting other places in the face. And now they're using for muscle contraction headaches, supposedly, and an aberration of the muscle patterns firing the way they're supposed to. And they inject into those areas, but there's a problem with it. Botox can cause neural paralysis because that's what it is. It's a toxoid. But what's your opinion? How often do you see something that won't correct in somebody because they've continued to have injections in their head with Botox?
I mean, I think it goes with the number of times I get in the injections all the time. I think if paralysis. To me, when you're looking at something like this, try to put something back into normal. I mean, that's what it is. What's the normal position? What's the neutral position for the body to be in? What's the neutral position for the jaw to be in? When you start doing Botox on these different things, there always seems to come to with some type of side effect. And I think first, do no harm. Put the body back in a neutral position as much as you possibly can. I think doing these shots, you've probably seen more of the people in that aspect than I have, but again, it doesn't make sense to me to paralyze something. And where else does that create a problem?
There was an interesting article that was sent to me from People's Magazine, and there was a young woman, 35 years old, that had Botox. Really, you tell me a 35-year-old wants to have Botox injections to flatten. I mean, they're beautiful at that point in their life. Right. But she ended up paralyzed because of the Botox injection. And as I said, it's a dangerous thing, in my opinion. If you look up side effects of Botox, you go on PubMed, you go on Frontier, you go on to Townsend Letter and so forth, and there's a risk level here that far more than many other things that we would think about. So that was just, part of the puzzle. In our world, we talk about the misalignment of the occiput, the skull, the upper cervical vertebrae, C1 atlas, C2 axis. And those are primary distortions. And we see people with, as you said, technic, their head down like this all the time, and they're reversing the natural curvature of their neck. That causes not only compression of the nerves, but an inflammatory reaction. So what's worse? Is it uh, the fact that they don't compensate for it, or is this something that we have to modify? You're the ergonomics guy. How would you go after and deal with this?
Well, I think one of the things is like chicken or the egg. If you go one direction, there's multiple reasons why it happened. You get overstretched ligaments. And I think one of the things that people don't realize, it takes about 20 minutes for the body to kind of reset its position. And the body, the brain, and the anticipation of what does this human want to do? Okay, well, I want to be dropping forward, looking at something and reading something for a little bit. We don't have all these emergency alarm things that tell us that you can't do that because it might be something important for you to do. So you do it. It's the problem over a period of time that we don't get sensory back tell us like, that's not a good position. Your ligaments aren't changing. And then let's say being at a job, I'm there for 4 or 5 years. And the next thing you know, I wake up in the morning, I'm like, oh, why do I got a little bit of neck pain? No big deal. And as you talk about, Tom, as being the yet disease, you have that once a week, and then it's now 3 times a week, and now it's 5 times a week. And you really take a look at an x-ray, and you see the whole person's neck is reversed. Those ligaments are overstretched. Muscles are getting tighter. The body tries to compensate the best it can, but there's a pain line, a threshold it gets to, and all of a sudden when you hit it, it's hard to get out of it.
There's 2 nerves that present quite often relative to producing pain. One is called the greater occipital nerve, and the other one's the lesser occipital nerve. One comes up over the top of the head like this, and the other one comes around the side. So people end up with these stabbing skull-like pains. And where does the nerve exit from? The back of the neck. And so when that upper area is overstretched, or when there's rotation in there that should be there, somebody's on a computer screen and their head's turned like this all the time and they're looking down, they're causing a distortion, or they're looking the other way, or they're constantly tilting their head in one form or the other. Those nerves are getting crunched or stretched. Subsequently, the triggering mechanism is what's called pain, and everybody's out to try to normalize it. How do we identify it, Scott? How do you go in a day-to-day practice that you're looking at identifying a structural component and where it's coming from, and setting aside the inflammatory piece, which we'll get into this Wednesday night. And when people come, we're going to talk about the distinguishing factors between a migraine headache, which is basically a vascular inflammatory pathway, something, or a muscle contraction or inhibition with structural deviation and rotation. How, one, do you know it's that? And what are the steps that we take to treat?
First, good history. Does it represent more vascular? Vascular is going to generally have one side. If you're talking mostly, which is most of the vascular ones you think about, it's like migraines. It'd be like a one-sided headache that usually goes with it. The retention type of headaches are going to be across the band here. TMJ is going to wrap up around towards his, maybe migrate to the forehead a bit. Top of the head, back of the head, those kind of things. So does it relevant? Is it dull? Is it achy? Get a good history on it. Second is range of motion. Do you find I can go to one side, but the other side I'm freely movable? And it's like, wait a minute, I can't move to one side. Something's locking up. That's mechanically not working the right way. Now, one of the things we do in our office in applied kinesiology, we like to muscle test to see if a muscle facilitates. That means, can it hold under pressure and a decent amount of pressure? Or does it just give away? And what happens is that, again, that shows us an imbalance in musculatures that are not there. A lot of times that will measure up to, okay, what kind of work do you do? Do you work on a computer all day? Do you, what kind of, are you a mechanic of some sort? So you'll see those type of things play out. You'll see a muscle being weak. It won't facilitate the right way. The range of motion will be altered. There'll be pain on palpation. One spot is going to be, it's irritated and those kind of things. There'll be a history aspect to be associated with it, dull and achiness. Also, a good question is like, how long have you been doing this particular job? So those are things that play a part. And even the things that we didn't even think about is our darn cell phones, which are really doing a major impact on all this.
One of the interesting things diagnostically that I'll do with a patient is I have them, the test is called a Romberg's test. So I have them stand with their feet together and close their eyes. And often the patient will wobble one side to the other. years ago when we first learned about Romberg, said, well, it was a brainstem neurological problem.
Mm-hmm.
Well, it's not pathological necessarily. It can simply be a distortion, a misalignment of the upper portion of the neck. So then what I usually, if they, let's say that they sway to one side over the other, and you should be perfect within a 1 degree forward, back, so forth, within a short stride motion.
Mm-hmm.
And so then I have them tilt their head, or I have them rotate their head, or I have them, just bring it back like this. And I have them do it again in that position. And all of a sudden the problem goes away. They no longer have that aberrant postural pattern, which tells me that that's coming from a misalignment of the skull, the muscles, and the vertebral area. And so then that gives you another piece, say, oh, hey, listen, we've got that going on. It's the same thing with a modified test where you have the patient look at the wall straight up, and then you have them stand on one leg or the other. And the lower portion of the brainstem, the cerebellum, which can be affected by aberration and abnormal position of the skull and the upper vertebrae. If you have them turn again their head and then restand, and all of a sudden it becomes stable, it tells you that it's not a pathological problem, that it is a neurostructural, neuromechanical thing. And that tells you, yeah, we can get this squared away. And invariably you take x-rays of this patient, and the way we take them, we'll take an open mouth so we can see the upper part of the spine, a lateral and a lower portion as well. But what you see is that the head is locked in a backward position like this. It's almost stuck, and for some people but the vertebrae, the spacing between them is out of position. What that simply means is that nerve is being stretched, or that cord is being irritated, subsequently causing the pain. So in our world, we do structural manual manipulation very specifically, and we go after one area. We're dealing with structural patterns, structural headaches. What else would help that patient in combination, not separately, because we find that things work hand in glove, if you will. And you're evaluating the patient. How would you set up the treatment program, and what's your rationale behind it?
Well, sometimes another thing we talk about is, we do a little bit of quantum neurology, which is actually some of the things to take a look at. And when you're looking at going back to that position, one of the things I would, like I said, do is do the cranial nerves, but do it in different positions, because that could create the reaction that they're having. How many times have we had somebody where you lay them on the table and you're like, okay, it doesn't show, but when you stand them up, it does. Or when they sit, it does. So you have to put them in the kind of position to create the problem. Quantum neurology is another interesting thing too, because if you actually stimulate using low-level light therapy, cold laser therapy, you can actually stimulate some of these nerves to actually react and come back. I have a gentleman I was working on. He was biting on the inside part of his cheek, and just using the cold laser aspect, find the right head position, putting that, and then cold laser on top of that, he took care of the problem. There was no reaction. It's been a couple months or so, and he still hasn't bit his cheek yet. So I think the thing is truly finding this position. I think another thing, talking about, like you talk about the Romberg's test, and you're looking at those things that create some of these things. You also got to think about when we walk in gravity, where our eyes are supposed to be level to the horizon. We want our eyes level so we can actually see where we're going. It's a danger type thing. If we tip our head in the vestibular aspect and the fluid in our ears are off, then all of a sudden we're going to feel like when we have the coordination, we're going to fall over. A lot of work I do is we don't realize how much the jaw plays along with our pelvis. There's a muscle called the glute medius. And if you abduct the leg out to the side and it's weak, you have them bite down on the jaw, and all of a sudden they feel better. And there's amazing differences in athletes who, if this position is out of position and affects their pelvis position, they lose jumping height, maybe strength in regards to bench pressing and things of that nature, how much this plays a part mechanically, and just the lever systems that happen throughout the whole body that makes that work. I mean, I don't know how many times you have somebody with a flat or a lost arch of their foot giving them headaches. It's kind of like Jenga. You play that game, you pull the stick out on one side, you go to the other side, pull, and it goes, and it's not necessarily always up on the same side. There's a crisscross pattern that happens too. So there's a lot of those things.
Well, that's the old song, the ankle bone is connected to the knee bone, connected to the hip bone, and so
Well,
forth. And that's
jaw's
really
connected to the hip bone. Hate to say it, but that's the way it is.
there's a bone right here, and it's called the hyoid bone, and you have 7 muscles on either side that connect it and balance it, and much of the literature is called the gyroscope of the body because it keeps your head balanced straightly. If those muscles are off, either because there's some kind of aberration that took place, people do this, they sit there like this all day long. They're putting pressure not only in their jaw, but they're distorting the muscle connection here. Those are all the pieces that have to be taken into consideration. Some people, are a result of things that they've done over the years. It's like the reason I do what I do today, and I've mentioned it many times when I give a lecture, is because of my wife. Sue had migraines from the time she was 5-6 years old. Years go by, and what they wanted to do medically is they wanted to fuse her neck from the second vertebrae down to C7 because her curve was fully reversed, and they were sure that it was a cord problem. But I said, I don't think so. So we had her treated at the Elgin Chiropractic Clinic in Elgin, Illinois, and where they do very much engineering Gonstead type of adjusting. And within 30 days, her migraines were gone. And then she stayed under care to get the curve back, just like dental bracing to reconstruct the normal aperture of the mouth. We did it to get her spine back to where it needs to be. But that's why I said, oh my God, what we do and how we do, once people understand it, is so far superior and not invasive. And the piece that you were alluding to with the one patient is that the fix in most cases is permanent. As long as the patient then corrects some of the lifestyle stuff. Sue had the problem because she's a student. Her head was always down like this. And so she was reversing the curve. You graduate from high school, class of 903 people, and you're number 2. And, through college and the same thing. So that was constantly giving her that distortion pattern back in the day when there wasn't a tech neck, but she was a reader. And, constant. She consumed literature like it was going out of style. So that's what we see, and we see it on an ongoing basis. I know this week is going to be fun going back and forth as it always is with you when we do our program this coming Wednesday evening. It's always a blast because we feed off each other, and it's great. I want to do some demonstrations as well.
Absolutely.
And show people what really takes place when the structural system, the spinal system, is not working the way it's supposed to. And if you can identify it, you can show it, you can fix it. And that's the beauty of it. If you can point to the cause, you don't have to dumb down the cause with a drug. You don't have to dumb down the cause with something that is temporary. You don't have to submit to surgery. You don't have to put Botox in your body to allow the muscles. And I know there's a lot of people, a lot of women out there say, but I need my Botox because I have to keep my face flat. Well, now they're even coming up with neurotoxoid Botox creams that you can put on your face. And so there's a different way, my friends. You can fix this stuff. You get somebody like Dr. Scott, who really gets it, understands the neurological background, the ergonomic patterns, the nervous system and how it works and so forth. This is an opportunity really to dig through the weeds and make it happen. But Scott, I'm looking forward to a Wednesday evening with you, as I always, it'll be fun.
Yeah.
It's one of those things that, that we do ongoing at the Roselle Center in Fairfax. And hopefully it'll give people an option instead of drugs, instead of surgery, instead of Botox, instead of all those things that can cause significant, permanent, lifetime secondary effects. And it's unfortunate. Scott, thank you. I really appreciate it.
Tom.
And, we'll tag team this Wednesday evening. It'll be a great time.
Yeah, let's have some fun Wednesday. That should be good.
We're going to have a great time Wednesday.
All right.
We're coming up to the end, and we got another program for you next week that I think that you're going to enjoy. Stay tuned. We'll let you know, online what it is. Remember that if you want to be notified when we're going live, all you have to do is go to drtomroselle.com and follow me, or follow me on any of your social media sites, whether it's YouTube or Facebook or Instagram, and it goes on. I think we're on all of them. So do that. Follow me. We'll let you know any information that we're doing that's brand new. You'll be the first to hear about it. And remember, we do this and the radio program and all the educational platforms we do simply for this reason. You deserve it. And we love you all. Have a great day.